A 50-year-old man walks into your clinic complaining of a swelling in his right groin. He says it's been there for a year. You are sitting in the hot seat of the Saudi Commission for Health Specialties Viva exam. The examiner is waiting for your next words. A candidate who immediately blurts out the diagnosis of inguinal hernia will fail this station. The board evaluates your discipline in executing a safe, algorithmic workup to rule out underlying triggers before you ever touch a scalpel. You are being graded against a hidden, highly specific point rubric. Every skipped protocol is a direct deduction from your final score. To pass, you must suppress the urge to make intuitive leaps, and instead vocalize a rigid, systematic chain of surgical logic. Your first move is to structure the history taking. You must start by characterizing the primary complaint. You tell the examiner you will ask about the lump's duration, how it initially appeared, its progression over the past year, any associated pain, and whether the swelling is persistent or intermittent. This section of the rubric shows the baseline marks for describing the mass, but the true test lies in the next 3 items. You must explicitly screen for a chronic cough, constipation, and urinary symptoms. Each carries a heavy weight on the score sheet. A chronic cough, straining from constipation, or difficulty voiding urine all drastically increase intra-abdominal pressure. Skipping these questions signals to the examiner that you treat hernias as isolated anatomical defects, rather than the secondary result of a systemic pressure overload. In a 50-year-old male, urinary symptoms are a mandatory screen for benign prostatic hyperplasia, or BPH. BPH is an enlargement of the prostate gland that physically obstructs urine flow out of the bladder. Repairing the hernia without treating the underlying prostate obstruction leads to surgical recurrence. A high-scoring history maps out the mechanical failures driving the abdominal wall to give way in the first place. Next, you transition to the physical examination. You must explicitly tell the examiner you are starting with the patient's general appearance and vital signs. Then, you specify that you will examine the swelling in 2 distinct positions. Gravity and intra-abdominal pressure force the contents outward when the patient is standing, while lying supine allows the anatomy to relax and often recede. Once positioned, you run through the visual inspection criteria, documenting the exact site, size, shape, surface texture, and overlying skin color. You follow this with the tactile assessment. You state you will check the temperature, determine the composition of the mass, assess its reducibility, and physically examine the superficial and deep hernial orifices. This is where candidates often relax, thinking they've covered the groin, and immediately lose 3 points. This specific line on the rubric strictly demands a full genital examination and a PR. A PR, or digital rectal exam, is a physical assessment where the physician palpates the prostate gland through the rectal wall. The examiner requires this to physically validate the urinary symptoms you screened for in the history. Only after clearing this protocol do you give the examiner your clinical finding, a right inguinal swelling that is completely reducible, locking in your diagnosis points. The physical exam physically validates the systemic risks you investigated during the interview. With the diagnosis secured, the examiner asks for your management plan. Do not rush to book an operating room. Your immediate priority is to establish objective medical fitness for a middle-aged man facing anesthesia. This list of investigations dictates the required workup: a complete blood count, electrolyte levels, a chest X-ray, an ECG, and a formal medical consultation. Once internal medicine clears the patient, you pivot to the administrative sequence required to get him to the table. You state that you will inform your senior attending and arrange for admission or clear the patient for day surgery. The remaining points in this section of the score sheet are entirely dedicated to strict operative safety. You must vocalize securing informed consent, ordering on-call intravenous antibiotics, and initiating DVT prophylaxis. DVT stands for deep vein thrombosis, a potentially fatal blood clot in the leg that can form when a patient is immobilized during and after surgery. Finally, you must state that you will physically mark the site of the operation on the patient's right groin. Wrong site surgery is a catastrophic never event, making this a heavily weighted safeguard on the board exam. You close the management phase by confirming the 2 surgical options, a laparoscopic or an open repair. A consultant surgeon prioritizes administrative checklists and hazard mitigation long before the first incision. The examiner now pushes you into the final phase of the viva, a rapid-fire assessment of your complication awareness. Listing generic post-operative complaints will not earn marks here. You need to identify the exact hazards of dissecting the tightly packed anatomy of the inguinal canal. The official grading criteria for this section demand exactly 7 precise complications. You start with the immediate systemic risks: postoperative hemorrhage, surgical site infection, and acute urinary retention. Then you must demonstrate your respect for the surrounding structural anatomy. You name the risk of inadvertently injuring the urinary bladder or perforating the bowel while reducing the hernia sac. Finally, you highlight the risk of transecting the vas deferens and the danger of postoperative neuralgia. Neuralgia is severe, chronic nerve pain caused when delicate nerves traversing the groin are entrapped by sutures or surgical mesh. True anatomical mastery is proven by your ability to anticipate and name the structures you are most likely to damage. You have now walked the examiner from the initial presentation through to the post-operative risk assessment. You secured the history points by linking precipitating factors like a chronic cough to the mechanical etiology of the disease. You dominated the physical examination by refusing to skip the critical genital and rectal assessments, and you locked in the management score by enforcing rigid safety protocols, from DVT prophylaxis to physically marking the surgical site. Executing this strict systemic algorithm under the intense pressure of the board examination allows you to confidently achieve a perfect score. Success in the SCFHS Viva confirms you have the discipline to apply surgical knowledge systematically to protect the patient.